of all, I'd like to thank everybody for attending this evening. I'd like to also thank IRG and Jensen and Shannon O'Kelly for co-sponsoring this with me and helping set up all the IT and technical support, which I have no idea how to do. But what I do know about is stem cell treatment. And I've been doing it for about 10, 12 years. What we're going to talk about tonight, we're going to talk about what we treat orthopedically, how we treat it, how it works, who's a good candidate, who's not a good candidate, and then the specifics of certain body parts and body areas that we treat. So just a quick little background on me. I've been practicing actually about 35 years now in the Seattle area. Founder of Seattle Sports and Regenerative Medicine. I was a senior partner and medical director of the Sports Medicine Clinic at the University of Washington Medical Center. Consulting team physician for the Seattle Mariners for about 20 years. I am board certified in primary care and sports medicine and ER medicine. I'm a fellow of the American Academy of Family Practice and a diplomat of the American Board of Family Practice. So now we're just a quick overview, and then we're going to go into each one of these specific categories as to what we treat with stem cells. Starting in the left lower corner of this circle, synovitis. Synovitis, anything with itis on the end just means inflammation. Synovitis is inflammation of the synovium, which is the tissue that lines joints. Okay, so inflamed joints that maybe don't necessarily have any other issues going on, we treat. Osteochondral defects. Osteochondral defects are chips or craters or holes that develop in the cartilage that go through to the bone, most commonly in knees and ankles, but we do see them in other joints. Obviously, the big one is osteoarthritis, and that's wear and tear arthritis. But we also treat joints that are affected by rheumatological conditions such as rheumatoid arthritis, lupus, and a whole host of other conditions. Meniscus tears, labrum tears. A lot of people don't know what labrum tears are. The labrum is the meniscus of the shoulder and the hip. And we see tears there all the time. We treat them just like we treat meniscus tears in the knees. Partial anterior cruciate ligament tears. And then there's the jury is out on complete ACL tears. I'm going to talk about that in a little while. Rotator cuff tears. Do a lot of rotator cuff tears. Chondromalacia is damage to the cartilage in a joint, but it hasn't yet started to affect the underlying bone. It typically is like cracks and fissures and craters within the cartilage that can cause pain. And then tendon injuries. We treat a lot of patellar tendons, Achilles tendons, elbow tendons, from tennis and golf elbow. So now we're going to kind of look at each one of these things. So osteoarthritis, the number one thing we treat with stem cells. Osteoarthritis is breakdown of the Teflon covering of the joint, which is the articular cartilage. It's the smooth, glistening surface. When you break a chicken drumstick or a turkey drumstick off that white, glistening surface, that's the articular surface. Well, in osteoarthritis, it breaks down. And initially, you just kind of get some thinning, some cracks, some fissures, some craters, but then it can get to the point where it deforms the knee joint, and it can get to the point of it being bone on bone, which this picture is a pretty good example of, although there's still a little bit of joint space on the left side. But this is a picture of somebody with fairly severe arthritis. I actually just put this photo in here a week or two ago because this is a patient I did 10 years ago who was scheduled for a total knee replacement and absolutely did not want to go through it. She'd had some relatives who had bad experiences with it. And I said, boy, oh boy, you got pretty bad knees. And you might want to talk to the surgeon. No, did not want a total knee replacement. So we ended up doing stem cells. She is 10 years out, and she was just in to see me a few weeks ago to tell me how, for some other joint, to tell me how fabulous her knees are doing after 10 years, even with bone-on-bone defects here. We do see arthritic changes like this when patients that have rheumatoid arthritis and other autoimmune type phenomenons. Stem cells work very well for those as well to treat the specific joint. It's not going to treat rheumatoid arthritis. It's not going to treat lupus. It's not going to treat mixed connective tissue disorder, different things, but it will specifically treat the joint that had been affected by it. Osteochondral defects, or what we call OCDs. These are like craters, defects in the cartilage that go down to the bone, usually in kind of a limited one particular area. We see them in younger people all the time, most commonly in knees and in ankles, can be a result of an old ankle sprain or a knee injury. We see them a lot in adolescence. And in adolescence, when your growth plates are still open, these have a very good chance of healing on their own. Sometimes I'll just do PRP, which we'll talk about later, to aid these and help them heal a lot quicker. Meniscus tears. Everybody's heard of, the tears that you have you have two menisci in your knee, the medial side and the lateral side. So here's an example of a meniscus tear right here. Here's an example of a degenerative meniscus tear. Oftentimes, if you have significant arthritis in the joint, you're going to end up with degenerative tears in the meniscus. So for years and years and years, the only thing we knew how to do was say, oh, you got a tear in your meniscus. Well, we're just going to have to cut out that meniscus. We're going to have to cut it out, the portion that's torn, because the meniscus does not have a blood supply, with the exception of this outer 5 to 10%. On this picture here, it's kind of a pinkish red. If you have tears way out there, they'll sometimes heal if we put a couple sutures in them. But the tears in here have no blood supply. Therefore, the only thing the surgeons can do is cut them out. Well, that's not a good thing because the meniscus plays a significant role in the knee for basically cushioning and stability. So if you take it out, 85% of those patients are going to end up with osteoarthritis later in their life. So what we want to do, we want to preserve that meniscus. We want to heal those tears. We don't want to just cut out the meniscus. And we can do that by putting a blood supply there, which is what stem cells basically does. So labrum. The labrum is like the meniscus of the hip joint and the meniscus of the shoulder joint. However, it's a little bit different in the fact that it's almost more like a gasket that provides stability for those joints. Those joints have a great deal or a significant amount of range of motion. They're very unstable joints. They move all over the place, which is what they're intended to do. So the labrum basically provides more support for the joint. Same thing, no blood supply. So all you can do surgically, take them out. Not a good thing, especially in the hip, because it's a very hard, difficult surgery to do in the hip because it's such a tight joint. And you have to basically put, some people like 100 pounds of traction on the leg in order to get to those labrum tears. Well, when you do that, sometimes you end up damaging nerves, which can be a big issue. Partial ACL tears, anterior cruciate ligament, the big ligament in the middle of the knee, okay? When they're partially torn, we can heal them with stem cells. I typically do not do complete ACL tears, although there is some data out there that says that you can treat complete ACL tears. I have a patient who came from Norway. She's an Olympic silver medalist, a Nordic skier, who she brought me her MRI. She had a complete ACL tear. She had stem cells done in Norway. And then she brought me her MRI a year after her procedure. It showed absolute complete healing of her ACL. I was checking the spelling of the name on the MRIs, the dates, the time, and yeah, her exam was normal. She actually was bringing her mother to see me, but so since then, I've had a patient who's an elite, kind of a world-class athlete, who has had 2 ACL tears. She came to me 4 years ago, and I said, oh boy, I'm going to send you to one of my buddies over at UW because you have a complete ACL tear. You need surgery. She said, no, I do not want surgery. I've done a bunch of research on this and I want to do stem cells. I said, well, I got to tell you, there's not a lot of good data out there that says that we can heal complete ACL tears. She says, no, I'm fine. If it doesn't work, it doesn't work, but I want to do it. So we did her. I kind of lost her to follow up, but she followed up with me about 6 months ago because she tore her other ACL in her other knee. And she said, you know what? This one is doing so fantastic. I want to do the same thing. I want to do stem cells. Sure enough, she had a complete ACL tear on the other knee. We treated it with stem cells. She has done completely fine and has had complete MRI documented healing of her ACLs. I don't know. I still am somewhat reticent to do complete ACLs, and I oftentimes at least ask the patients to get a consult from the surgeon on those. Rotator cuffs. If you have an acute, complete rotator cuff tear where you can't lift your arm up past 60 degrees, then we need to talk about surgery because you have to go and you have to suture the ends. However, if it's a chronic tear, if it was like a year or two ago and the ends have kind of shriveled up and the muscle and tendon have atrophied, oftentimes there's no way surgery is going to get the ends back together, nor will stem cells. However, we can augment the rest of the rotator cuff. We can get rid of the pain. We can rehab it and improve strength and flexibility in the joint. Now, for partial rotator cuff tears, the problem with partial rotator cuff tears is if you do surgery on them, where those tears are is in an area called the avascular zone. It's got a really poor blood supply right up in here. That's why they all tear in those areas. So if you go and you put a bunch of sutures in a partial tear, you compromise the blood supply even more, and there's a 60 to 90% failure rate within 5 years. Biologics, which is stem cells, work significantly better than surgery for partial cuff tears because we can heal those tears completely by, once again, putting a blood supply there. Chondromalacia. So this is kind of a precursor to osteoarthritis. It's where the cartilage, and most commonly where we see it is behind the kneecap, but we see it elsewhere too. It's where the cartilage starts to get damaged, thinned, gets cracks and fissures, but there's not yet underlying bone damage. So it's not what we call osteoarthritis, but it's chondromalacia. Typically, a lot of runners, basketball players, jumpers get this issue, pain behind the kneecap. They've done physical therapy. They've done everything. It's still hurting. Stem cells work really well for this type problem. I see a lot of tendon injuries like patellar tendon, Achilles tendon, elbow, golfers and tennis elbow, and basically we treat these all the time. The one exception is if somebody has once again a complete tear of their Achilles tendon or their patellar tendon, I send them to the surgeon because the stem cells, typically when those tear, they pull apart, and the stem cells are just not going to bridge that gap. Synovitis, once again, it's inflammation of the tissue, this like feathery tissue that lines the joint. Responds very well. Oftentimes I'll just do platelets or PRP for synovitis if I don't need to regenerate any tissue. Okay, so now we'll back up. We talked about what we can treat orthopedically with stem cells. So regenerative medicine is the field of study that utilizes stem cells to heal and regenerate damaged tissue. What we do is we use only autologous, meaning from your body, adult mesenchymal stem cells. Adult mesenchymal stem cells can grow up to be bone, cartilage, muscle, and tendon, and that's it. We don't want all these other 206 different types of stem cells. We just want the mesenchymal stem cells. And we are able to isolate just those by virtue of a very complex software program that was developed by a buddy of mine who ran the molecular biology department at Stanford, and just a brilliant guy. And we're going to get, depending upon the patient's size and age, anywhere from 2 to 4 billion of those cells. The stem cell itself is an unspecialized cell in your body that has the ability to renew themselves and also transform into what we're talking about, chondroblasts, myoblasts, cells that can lay down new cartilage, new tendon, and new bone. Okay, this is just about a 4-minute, kind of a very simple little cartoon video that kind of gives a good overview of stem cell therapy.
What is stem cell therapy? Stem cell therapy is an injection treatment designed to heal injuries and reduce pain. It is used for arthritis and injuries to ligaments, tendons, muscles, cartilage, and bone. First, let's look at the difference between human embryonic stem cells and adult stem cells. Embryonic stem cells are pluripotent, meaning that they can become of any of the more than 200 known differentiated cell types of the human body. On the other hand, adult stem cells are multipotent, meaning that they can develop into more than one cell type, but are more limited and controlled, and thus safer than pluripotent cells. We perform the adult stem cell treatment. What is the role of these stem cells? To understand this better, let's look at this example. Your house is exposed to different elements, such as wind, fire, rain, sun, and time. All cause damage to the structure. To keep your house in order and repair any damage, you need different professionals like firefighters, construction workers, insurance agents, and a contractor to supervise and direct the project. This is no different than your personal life. You need a dentist, lawyer, financial advisor, doctors, insurance agent, and a barber, along with other professionals. So, both your house and your life require different professionals and specialists to keep them working well. And your body needs stem cells. Now, let's dive deeper and see what happens to your joints. In a normal healthy joint, you have plenty of stem cells. These cells are not only capable of doing maintenance and repairs, they also know when and where these repairs are needed. The stem cells work as a contractor that, in addition to giving instruction for repairs and maintenance, can transform to specialized cells to do whatever is needed to fix any problem. When you have enough of these stem cells, there is a balance between damage and repair, and you have no pain and no injuries. Think about when you were 18 years old. You were able to run, jump, and do the same the next day without pain. The only problem is that with time, the number of these stem cells goes down, or sometimes the severity of the injury or damage is more than the ability of your body to repair it. This leads to an imbalance and ultimately leads to arthritis, injuries, and pain. In essence, as you age, you have a lower number of contractors and workers available to do the job, or sometimes the amount of damage is too much for the available stem cells. But fortunately, there are areas of your body that keep a good number of stem cells. These areas include the bone around the hips and the fat in your abdomen and buttocks. And this is the key to stem cell therapy. The doctor will take stem cells from one or both of these areas and transfer them to the area of injury or arthritis. This will provide the stem cells needed for repair. In essence, the treatment will supply the manpower needed to do the job. Once there, these cells secrete growth factors that will organize and coordinate other cells to do the repairs. This leads to healing. This is like the contractor giving instructions to get the job done. This treatment can be used for pain with injuries coming from ligaments, tendons, muscles, bones, cartilage, and meniscus. When is it useful? If you have an injury or an arthritic condition that did not improve with therapy, medication, other injections, or surgery, or if you were told you need surgery, then stem cells is a great option for you. Thanks for watching.
Okay. Oops, maybe I need to stop that. Oh, there it goes. Okay. So how do these cells work? Let's go back first of all. When we were 10 years old, I mean, you had hundreds of billions of cells, stem cells, circulating around your body. When you get to be 60,
Hi, Ninja Nerds. In this video today, we're going to be talking about hemodialysis.
oh,
But before we get into it, make
back
sure you
there.
go over and check out ninjanerd.org.
We
That's where
got-
all our notes and illustrations for all the lectures that we put up here on YouTube are available for you guys to utilize. And then comment, subscribe,
Jensen, we
and
got a
hit that like if
problem.
you can for this video.
It'll
Let's
be
get started now with
on that other
hemodialysis.
screen again, the
So when
tab.
we talk about
I think
hemodialysis, as we
open
finish
another
through
one.
our renal series here, we're focusing on why
Somehow we got
patient needs
another YouTube
hemodialysis,
video here.
what is hemodialysis, and then how do we care for the patient through hemodialysis as the nurse? How are we caring for them? What are we doing for them? So the first question we want to answer is, what is hemodialysis? We have a patient who has lost function.
And then
so
just close out of those tabs at the
function
top
in their
there.
kidneys. They're having a really
See if we're gonna
decrease
get
in
off
function,
of
the ability
here.
for their kidneys.
And reduce pain.
There we go. Okay, sorry about that. All right, so yeah, so when you were 10, you had hundreds of billions of stem cells circulating around in your body at any given time. When you hit 60, you drop down into the hundreds of thousands. So you don't have as many stem cells, but there are these localized pockets. There are these areas in your body where, specifically bone marrow and fat, where you still have a very significant number of stem cells. I mean, we've done over 300 patients in their mid-90s who've done fabulously. We actually had a woman a couple months ago, 103, and she was referred by her 101-year-old friend who had had her hips done. And they both done fine. Yeah, I mean, you don't have as many stem cells as somebody who is, 35 or 25 and plays lineman for the Seahawks, but you still have plenty. So the platelets, the stem cells, all have these regenerative properties as well as anti-inflammatory properties. So the other option for a lot of patients where they're coming to see me because they went to see the surgeon and they said, oh, you got to have a total knee replacement. Well, the big data on total knee replacement, 65 to 70% of patients are happy with a knee replacement. But that means 30 to 35% are not happy. And, the pain can be worse afterwards. I see the disasters here because people come to me a year or 2 or 5 years after a total knee and they said, Doc, it's worse now than ever. And I'm having all sorts of problems. And plus there's other issues such as, no, I'm actually going to move on. First of all, it's a big surgery. It's a year of rehab. And some people are just not candidates for that, depending upon, their weight, their age, their possible other medical conditions. Some of the complications of total knee replacements, infection. Sometimes those joints get infected. They have to take them out. They have to put a spacer in, put people on IV antibiotics for months and months, and then hopefully redo the surgery 6 months or a year later. Blood clots in the calf is fairly common, which can sometimes go up to the lungs and create a pulmonary embolism, which can be very, very severe and even fatal. Heart attack and stroke. There's a couple studies out there that say that men and women over the age of 60 who have total joint replacement, specifically total knee, men have a 30 times greater incidence of heart attack in the year following the total knee replacement. Women have a 25 times greater chance of heart attack and stroke. Joints do not, especially knees, do not last forever. They tend to last anywhere, depending upon your size and how much stress you put on them, anywhere from 8 to 15 years. There are a lot of studies out there that are looking at the possibility that there's an increased incidence of dementia. And that is because of chromium, cobalt, nickel, and titanium, heavy metals in the bloodstream from the actual prosthesis. And then the other thing is your body mass index. When patients have body mass index over 30, all these complications, the risk factors go significantly higher. So what do we do before the procedure? We stop anti-inflammatories because the way this works is you need inflammation in order to heal. So platelets, which is PRP component of the procedure, create inflammation. We don't want to stop that. So we don't take Aleve, Advil, ibuprofen, Motrin, CBD, turmeric, those type things. We like patients to drink lots of water, it just makes the blood draw easier to obtain the platelets. There are certain medications, such as blood thinners, that we may need to modify before the procedure, depending upon what they are. So what we do, the patient comes in, they do need a ride, not to come in, but to leave. We just think it's a good idea. We draw blood. From the blood, we isolate platelets. So it goes through a computerized centrifuge, the blood layers out, and we pipette off what's called the Buffy coat, which are all platelets. We then inject those, or we hold on to those platelets. We then do bone marrow extraction. The post kind of, you got your spine and then you got your pelvis on both sides. We go right to the pelvis. It's nowhere near the spine. And we withdraw stem cells from bone marrow. Kind of in the same area, kind of in that flank or love handles area, we do mini liposuction because we get a lot of stem cells from fat. So the stem cells we get from bone marrow are long-lived. They're a little more robust. The stem cells we get from fat are prolific. We get lots of them. Then we have 3 separate syringes. The stem cells from bone marrow, the stem cells from fat, and then the platelets. And we use ultrasound to guide our injections into the tendon, the muscle, the joint that we're treating. The whole process takes about an hour in the office. It's a one-time process. And then the patients basically go home and start physical therapy the following week. We do not do procedures on people who have significant medical problems where they have bleeding disorders or they have to be on blood thinners such as Eliquis and Xarelto. Typically, patients can stop it for a day or two, or we can do something called the Lovenox bridge. So it's rare that we have to tell patients they're not a candidate because of the blood thinners. Infection, if somebody comes in and they said, Doc, I got pneumonia or I got bad sinus infection or I got a tooth infection, we want to wait, until that's cleared up or at least treat it. And if somebody's got certain types of cancers or is undergoing chemotherapy or, has metastasis, then we kind of need to talk to the oncologist and figure out, what the appropriate plan would be. So one thing, there are unfortunately a lot of bad actors out there, people who are doing stem cells but using allografts. In other words, they buy stem cells online, typically comes from south of the border, from women who are willing to sell their placentas. There are 0 live stem cells in that product. So what oftentimes it can be a chiropractor, naturopath who hires nurse practitioners to do the injection. They buy the stem cells online, they mix it up with some sterile saline and then inject it. I've seen some real disasters from that, bad infections, increased pain afterwards. We even had one patient who ended up going on, unfortunately, after about 3 months, to an above the knee amputation because of it. So results, talk about that next. So patients who have mild to moderate osteoarthritis, about 80 to 85% of those patients are going to see 75 to 80% improvement. Our patient population, over 20,000 patients, and this is from patients who have mild osteoarthritis all the way to severe. Overall, 91% of our patients see at least 75% improvement. The nice thing with stem cells is there's no downside. Nobody gets worse. We're only using your own cells. It's a very safe procedure. As long as you use your cells, there has not been a single serious adverse event reported on the FDA database. So I've got a few major scientific journals and clinical studies that talk about, these are the highlights of the studies. I'm just going to go through a few of them. From the Journal of Bone and Joint Surgery, there was evidence of meniscus regeneration and improvement in knee pain following treatment with human mesenchymal stem cells. These results support the study of human mesenchymal stem cells for apparent knee tissue regeneration and protective effects. Now, this is this is purely an orthopedic journal. From, once again, another orthopedic journal, Journal of Clinical Orthopedics and Trauma. The versatility of stem cells as treatment modality has landed it another repair target, osteoarthritis. Through many studies, this newly discovered method has been shown to significantly alleviate pain experienced by osteoarthritic patients. From Helion, which is a British medical journal, this study showed that a single intra-articular injection of bone marrow stem cells appears to provide long-term benefits. The procedure is simple, fast, well-tolerated, avoids the need for hospitalization, and generated no complications or adverse effects. From the Journal of Orthopedic Translation, in contrast to traditional treatments based on drugs, proteins, or antibodies, stem cells are poised to revolutionize medicine as they possess the capacity to replace and repair tissues and organs, such as in arthritic joints. From Nature, the British Scientific Journal, in conclusion, mesenchymal stem cell treatment improves knee pain, physical function, and cartilage quality without any severe adverse effects. From Mesenchymal Stem Cells and Regenerative Medicine, cartilage mapping by MRI showed evidence of improvement in the good cartilage quality and significant decrease in poor cartilage quality. So basically, these were second look with arthroscopes after stem cells. And one was actually with MRI, and it showed complete filling of defects like osteochondral defects in 12 out of 15 patients. And then they looked 2 years later with scopes in the knee joint and could see smooth, newly formed tissue, and that the implant stability was similar to native tissue. Go through that one. And then one of the most recent ones, and this is the NIH, National Institute of Health, looked at the 34 peer-reviewed studies, large randomized studies, and their conclusion was, this study demonstrates that autologous mesenchymal stem cell injections provide consistent, clinically important improvement in osteoarthritic disease parameters, and that both the magnitude and the duration of improvement far exceed any improvement that may be seen from a placebo effect. Furthermore, the duration of efficacy out to 2 years, they basically just looked at out 2 years. So they said the duration of efficacy out to 2 years from a single treatment greatly exceeds that of any other non-surgical treatment or any possible placebo effect. In light of its excellent safety profile and the absence of safe, effective treatments for osteoarthritis, stem cell treatment should be widely adopted for the treatment of osteoarthritis. So this slide is a little old. There's now over 50 million cases done in the United States, no adverse effects. The nice thing is it's all local anesthetic. You're awake, you listen to music, you walk out. After the procedure, we ice it, we give you pain meds if you need it. Most of the time it's, most people get by with just Tylenol. You're still doing your activities of daily living. No, you're not going to go run around green light that day. Most people start to see improvement in the 6 to 12 week range. Improvement goes out to a year and then tends to level off. There's some data out of Japan that says 2 years. It is important to get in and see physical therapy. I usually start patients in therapy the week after the procedure. And then we just kind of rapidly progress to activity while at the same time protecting those stem cells. We don't want to be running and jumping on them because they're expensive. They're not covered by insurance. We don't want to damage any of them. And so that is pretty much what I've got. And then what we're going to do is open this up for, I think Jensen has a way that you can email or text in your questions. And I'm happy to sit here for as long as we need to go over everybody's questions. So Jensen, what do we do now?
Yeah, so if anyone has questions, they can come in the chat and Dr. Wagner can answer them.
You have to write it in.
Where?
Can you see their questions, Dr. Wagner?
No, should I go off of the no? So there's nothing that shows the. I mean, I could.
First question.
Oh, it's in the chat.
I can end the show. I can
No,
hide presenter view, show taskbar.
Yes, show taskbar.
Okay, I'm back to the Zoom. It's just a white screen that says Zoom on it.
You want to open the meeting chat so that you can see, yeah.
Open meeting chat.
So at the bottom of your screen, it'll say chat.
Let's go back. Let me see if there's something else here. Open meeting chat.
One of us could read the questions to him.
Download now. I don't see anything that says meeting chat. It's the only problem. Terms of service, download now.
Yeah, I can read them if you want.
Okay, you want to just read them?
Yeah. Can you do more than one joint in one treatment?
Yes, oftentimes we do. We have people come in with bilateral knees or bilateral hips or a hip and knee and a shoulder. The most that we can do at one time is 3 large joints. Still takes about the same amount of time. The one nice thing about doing it at the same time is you do the therapy at the same time. It also is significantly less expensive if you do more than one joint. Because everything is when we open up our sterile surgical kits, just to open up one of those is a big expense. So if we can use double kits or triple kits, it saves you quite a bit of money on the procedure.
All right, and that brings us to how much does this typically cost, and does insurance cover it? I'm sure it's
So unfortunately, insurance doesn't cover it. Insurance does cover consultations, follow-ups, physical therapy. Doesn't cover the procedure itself. The procedure, so a single large joint, I believe, is 7,700. If you do 2 large joints, it's like 11,000. If you do 3, it's like 15, I think, or something like that. Small joints are less. It just varies depending upon the joint. Now, some people do have, and it's certainly appropriate to use it like health savings account or flexible spending accounts, and you can use those for the procedure.
all right. 2 questions on thumbs. I'm interested in the use of stem cells for thumb joint therapy.
Okay, so actually I've done my thumbs. I have osteoarthritis at the base of my thumbs. I had one of my buddies back at Stanford do stem cells to both my thumbs. That was 8 years ago. It was just a game changer. I was at the point where I was having so much pain planning ski poles, fly fishing, tennis. Get a cortisone shot from one of my partners, and if I was lucky, I got a couple weeks of relief. So finally, I had stem cells done to both, and I mean, I've got basically pain-free thumbs now. It's been 8 years.
All right. One more. Would it help with a previous failed knee replacement?
So no, because all you have there now is metal and plastic. Now, what sometimes I will do, I have patients come in and we'll just see if we can decrease inflammation by doing a PRP injection. So that's one thing that might be an option. Other questions?
can it treat a bone spur coupled with arthritis?
I'm sorry, I missed the first part of that question.
If you have a bone spur,
Oh, bone spurs, I mean, a lot of the surgeons make a big deal out of bone spurs are typically on the periphery of the joint. So they're there because of the altered motion in the joint, because of the osteoarthritis. So the bone spurs themselves, unless you have a huge bone spur that's blocking your range of motion, they 99% of the time the bone spurs are not causing the issue or the problem.
I have
Hi,
a question.
oh, sorry. I
Yeah,
have a,
do those success rates, do they apply to every joint in the body, or are there some joints that it just doesn't work on? And then
So
a related question, does the studies that you cited were like in 2011 or so? Are
there
there,
are
have there,
there's studies that they range in dates. I'd have to go back and look exactly when they were.
okay. What about all the joints, ankles and spines in particular?
So I don't do spine. I'm just too busy with joints. But and the data for spine is not as good as it is for joints. Um, for ankles, yeah, we see really good data with ankles. A lot of it depends upon kind of the joint itself, the degree of osteoarthritis, the damage in the joint, what's going on there. So, I mean, I have some people who come in and, you know, have severe osteoarthritis, but maybe they've got heart disease or obesity and they're not a candidate for a total joint. And the surgeon sends them to me to do stem cells. And I'll say, you may only have a 50–60% chance at seeing improvement. And these patients are so thrilled to have an option. They're like, hey, I don't care if it's a 25% chance. I want to take a chance and see. Because the nice thing is nobody gets worse with the procedure.
Can you talk about the cost since it's not covered by insurance?
So the cost, okay, so a large joint is, I believe, 7,700. And then it diminishes if you do more than one large joint. It's like for two large joints, it's like 10 or 11,000. For three, it's like 15. Small joints range from a couple thousand to maybe 3,000 or 4,000. So yeah, it varies depending upon the joint itself.
I have a question. For people with like hypermobility on the spectrum, I have some ligament and joint laxity. I've been doing PRP treatments for 6 months. And it has been improving, but like this is like an unaddressed issue that's been going on for 10 years. I was considering stem cell for a faster recovery. I'm in my late 20s. Would that be good with somebody that's on the hypermobility spectrum that's had a few car accidents and now has joint tendon laxity?
It might be. It would be something that certainly I would say, we should take a look at and see. I'd like to see images and the thing is, if you're seeing improvement with PRP, but maybe it only lasts 6 months or so, then oftentimes, stem cells can be a much longer fix than just doing the PRP. But it would depend. In those cases, and pretty much like I do with everyone, I'd like to, see the joint, see the images, and see exactly what's going on, and then, talk about what I think the percentages and the chances are. Do you have Ehlers-Danlos syndrome or is it?
No, I'm on the lower end of the hypermobility spectrum. I
Okay.
just had a sports injury as a teenager in a car accident, and that just really strained all the connective
Okay.
tissue.
And have you had imaging of the joints?
I've had like MRIs of my back. I've been ruled out for arthritis and like nervous system issues. Everything's come back fine.
And what are the joints that are involved?
So I PRP like my costiovertebral joints, my SI joints, my TMJ, my shoulder. It's pretty much everywhere in my body.
Yeah, shoulder and sacroiliac joints, stem cells work very well, but it would be a matter of, I'd say set up a consultation and
Mm-hmm.
let's take a look and see, but you might be a candidate if you responded to PRP.
Okay, thank you.
All right.
Dr. Wagner, I have a question. I received stem cells about 11 days ago, and it was by a chiropractor slash he was a physician's assistant, and it was from umbilical cells, he said, and today I had it in both hips and my spine, and my hips feel more unstable and they ache more. And I'm wondering, is it the way he was telling me that you have to get worse before you get better? Is that true? Or should I be doing something else? I live in Alaska, so I'm not right there in Seattle, but I can make it if I had to correct something.
Yeah. Well, the thing about using umbilical cord, once again, there's no live cells, there's no live stem cells in that. And I mean, the kind of the way I look at this is not something that nurse practitioners or physician's assistants or chiropractors or naturopaths should be doing. They're just not, don't have the appropriate training for it. I mean, but anyhow, it can be sore, for a couple weeks afterwards sometimes. Um, so you typically what we see is you just don't get, a good response in the long run. Infection and things like that, typically it's usually around 2 weeks when patients start to get issues with that. So I'd be, really aware and make sure you're not getting the night sweats, fever, chills, increasing pain. And if that's the case, yeah, I go to the ER and get, have somebody take a look. What I do for many of my, because we see patients from all over the world, we do uh, Zoom consultations, with patients oftentimes where we get the images ahead of time. I get them on my desk, on my computer, and I can look at them, and then we talk to patients, online and see, if there's something that maybe should be done. And then it's, then patients fly in usually just for the procedure and fly home the same day or the next day.
We get the imaging before we contact them.
Okay, thank you.
Okay,
I have a question, doctor, if I can ask.
sure.
I'm in my 70s and I walk around fine, but I do have osteoarthritis where I've been told it's bone on bone in both knees. So I've been having these hyaluronic
Uh-huh.
injections, a series of 3. Is there any kind of complication or waiting period after having these types of injections that you want?
No, as long as they're not putting cortisone into the joint.
Okay.
There are some small studies out there that say even doing the gel with stem cells may increase your, level of improvement, your percentages. So no, it's an inert substance. It's basically putting Pennzoil 10W30 weight, in your knee joint.
Yeah.
And there's nothing wrong with that. I do it for lots of patients. So yeah, no problem. The cortisone, we tell people 6 weeks, but with the gel, no issue there.
Okay, thank you.
Could
Sure.
you speak about PRP and stem cell in hips, like moderately severe hips with osteoarthritis? Because it sounds like it works really well on knees and maybe on
Oh
shoulders.
yeah, no, we do. I'd say we do. We've done 20 some odd thousand patients. Most of them, are knees followed by hips followed by shoulders. So we do thousands of hip joints. Moderate, or moderately severe osteoarthritis works well. And yes, we do stem cells from bone marrow, stem cells from fat, and PRP. So you want to do all 3. That's the gold standard.
Okay.
And that's
Okay.
kind of what we're doing at Mayo Clinic, Cleveland Clinic, Hopkins, Harvard, Stanford, and that's what works the best.
Okay, thank you.
Sure.
For his own imaging.
Right.
Doctor, can you tell me what's the difference between small joints versus bigger joints?
Good question.
So as far as my examples of small joints versus large joints?
Yes, when you were talking about cost, you were talking about smaller joints.
Oh yeah, smaller joints are typically hands, thumbs, not necessarily wrists, but thumbs, the small joints of the hands, the small joints of the mid feet, the big toes. Those are typically small joints. Everything. So the large joints are ankles, knees, hips, wrists, elbows, and shoulders, and sacroiliac joints. So.
Dr. Wagner, question, if we were to come in, or if we were to make an appointment to come in, should we bring existing imagery, or would you just be doing it anyway? Bring it along then.
If they're recent, I mean, if they're years old, then we can just do it here. But if you got films within a year, just, yeah, bring a disc, bring a, a thing here, and I like to see those. And then we don't have to repeat,
Okay, great.
Doctor,
Oh,
I got a question.
Does the preoperative workup of imaging, I know the stem cell procedure itself is not covered by insurance, but if we get the imaging, whatever you need, be it X-ray, MRI, that type of thing, I know you said the physical therapy is covered by the insurance. Would that be covered at your
Oh,
office?
yeah,
Should that be done?
that would be covered by insurance, the imaging, yes.
Okay, thank you.
Sure.
Doctor,
Mhm.
my name's Mitch. I was in the military for 32 years. My body's basically broken. I've been on Celebrex for 16 years for my lower back. I've been given an offer of the placenta stem cells by IV treatment, and they say basically they send 1 billion stem cells into your body, and the stem cells go to where that word where it's what the Celebrex is saving me from right now. The issue is when I go off Celebrex, and I've done it twice, I become almost a cripple at that point.
Right.
So 6 weeks is kind of a long time to be in pain.
Yeah, there's other things that we can do. We put people on tramadol. We put people on lidocaine patches. I'd be very hesitant. Where are they telling you they're going to do IV stem cells?
What do you mean? They basically in our forearm?
Oh, no. Where's the clinic? Panama or?
No, this is in Spokane, and they're using a place called Platinum Biologics.
Yeah, I'd be very suspect of that because it is very much frowned upon, except in research facilities when we're treating ALS, Parkinson's, dementia, and Alzheimer's, that they're in study centers that they're doing IV treatment with what we call allografts, in other words, stem cells that you get from elsewhere. So it's a little bit of it's fairly sketchy. I know that they do it in the Cayman Islands and Panama, and people go down there and they spend $35,000 to have IV treatment, and there's just not a lot of good data out there. And typically, once again, they're typically like these chiropractic groups or naturopaths that are doing. There was a lady here on Queen Anne who lost her license for doing it. So I'd be really, really hesitant, really careful about doing that.
Okay, thank you.
I have a question. I have a question.
Yep.
Can you hear me?
Sure.
How do you determine if the cells are viable? If someone's had other treatment that could compromise their cells, how do you determine if they are the cells that you would be able to actually use for this procedure?
The only thing that might compromise viability of the stem cells would be if somebody had significant amounts of radiation treatment to their pelvis.
Okay.
Otherwise, I mean, here's the deal there's a guy at MIT who did this study. So stem cells are constantly regenerating tissue in your body. Constant, because you have constant breakdown and constant regeneration of tissue, that according to this study, and some statistician, molecular biologist, is that if you didn't have stem cells, you'd be dead within 20 seconds. So it's this constant repair and everything. So, I mean, everybody's got stem cells unless you have complete bone marrow atresia where you're not producing anything and you need a bone marrow transplant or something like that. So yeah, typically, patients have those cells, that we need to use and do just fine.
Thank you.
I have a very quick question. So for example, if a knee has like multiple issues, like condemnation, partial issues, and the meniscus state too. So how many stem cell injections would that be, or is it just like covered by one thing, or like would it be like multiple something?
I'm sorry, I can barely hear you. What was the question again?
So for example, if a knee has multiple issues, like partial ACLTs, chondromalacia, and meniscus tear. So will that be like 3 different injections or just one injection for the whole knee?
So typically, the plan is one and done when we do an injection for a joint. Every once in a while, sometimes we'll put some more platelets in at a later date, just kind of as a booster sometimes, if need be, for the stem cells. But typically, it's a one-time, procedure.
Right, and it treats everything in the knee, like
Oh
meniscus,
yeah, yeah.
ACL.
So once you're in the joint, you're in the joint. There's a capsule that surrounds all the joints. So those cells go only where they need to go.
Right, thank you very much.
Sure.
Thanks.
Another question, Doc.
Sure.
If you've had, I've had several rounds of chemotherapy in the past, would that be problematic for the stem cell therapy?
So are you still on chemotherapy?
No, I haven't been on for at least 2 years.
And it was for what type of cancer?
Stage 4 colon.
Okay. And how is that coming along now?
I'm, knock on wood, free.
Oh, thank God. Okay. So yeah, it shouldn't be an issue. Should not be a problem.
Thank you.
Sure.
Okay, Doc. You say you don't do spines. Lower back is considered the spine, right?
Right. I do sacroiliac joints. In order to do spine, you have to have something called a C-arm, which is a mobile X-ray live unit.
Okay, I know. Okay, and the next question is, a knee is considered a big joint?
Yes.
Okay, thank you.
Sure.
I have a couple questions, if you don't mind. One, I have recently been diagnosed with osteoarthritis in the top of my foot. I haven't heard you say foot, but I'm assuming this would work for something like that?
Yeah. Was it would you know the name of the joint?
Oh, I don't recall. I'm sorry, but I could.
Most likely it could be talonavicular joint. Is it up by the ankle or more down by the toes?
It's closer to the ankle.
Probably it could be the talonavicular or one of the mid-tarsal joints. Yeah, no, we treat those all the time.
Okay. And then as to go on the cancer, I have B-cell lymphoma. I am not having a treatment. They are watching me and monitoring me. Would that prevent stem cells to be used for me?
It shouldn't. We've had a few patients with B-cell lymphoma, but what I do is I usually give a call and talk to either your hematologist or your oncologist just to make sure they don't have any issues with it.
Okay. And then in my last question, my son broke his ankle. He's now 20. He was 16. No, he was not. He was like 14 at the time. He broke his ankle and he got 3 screws. He has been told he needs to get the screws removed now, but he has some issues with his ankles. After we remove the screws from his ankle, would that be stem cells be a good treatment for his ankle?
Sure. I mean, it sounds like could be that he's got, I don't know, but some arthritis maybe from the injury, or it could be that he has an osteochondral defect in the ankle. So yeah, that would be something we'd need to take a look at, see the images, and then kind of talk about what the options are.
Okay, and that would be after the screws are loose or removed, I would assume, correct?
So is he having problems with the hardware?
He gets some pain in his ankle from time to time, and I'm in Olympia, and we went to a local a doctor, and they said, well, you were so young and you've grown so much that, I think that you need to remove these screws. And we were actually told when the screws were put in there with his growth, he may need to remove them because it may cause pain over time. So they've suggested that they get removed because he does get pain in his ankle from time to time that can hurt quite a bit, and he's quite active. So it interferes with things.
Sure, sure. How old was he when he had the screws?
He was 14.
Oh, so his growth plates were still open. So, yeah, it might be that he needs to have the hardware removed. But yeah, I would say, either before, I mean, certainly we could always do a consultation, before or after, and then just figure out, what needs to be done first, second, whatever.
Okay, thank you.
Sure.
Doctor, say this all sounds pretty good. Can you kind of describe the timeline and the path to move forward? I have 2 knees and 2 shoulders, probably prioritize one shoulder and 2 knees.
Okay. So
and move forward that and see how it works.
the best thing is to first set up just a consult. Are you local or?
Yes.
Okay. Best thing to do, call first thing in the morning, set up a consultation. Usually we can get people in within, a week or two for a consultation, although I'm headed out next week, so I'll be gone for about a week and a half. But we get people in, consultation, and then typically we can get people scheduled for the procedure within a week or two of the consultation. The only thing that sometimes holds us up a little bit is if you have a certain type of insurance that's called Med Advantage, which it's kind of funny. It's not funny. It kind of pisses me off. But Med Advantage, we know they're not going to pay a penny for the procedure, yet they still make us jump through all their hoops to submit it, for them to pay for it, and they're going to deny it. They always do, but it basically holds up the process about 2 weeks or so.
I
But
have met a gap. Is that okay? And
I don't know, but a worst case scenario, yeah, it puts it off a few weeks after the consultation.
all right, thank you. Go to Tom next. He's had his hand up for a long time.
Okay. All right, Tom, wherever you are.
Hi, Doc. Thanks for doing this. I take warfarin. Will that mess with the stem cell procedure?
So let me ask you this. What do you take the warfarin for?
I had blood clots some years back, and the couple of them landed and stayed, and they wanted to make sure I didn't clot up and get something in my head.
Okay. And also, what joints are you talking about?
My shoulders are what are bugging me right now. They clatter and clack and hurt, and I've got osteoarthritis, and
Okay.
so that's what I'm interested in having you possibly, you and me, have a consult someday.
Have you ever been off the warfarin for a procedure?
Yes.
Usually go off at 2 days.
Yeah, when I had a hernia repair, I went off for however long.
And did you go on a Lovenox bridge, or you just went off it for 2
Just
days?
went off and
Yeah.
had to be very careful.
Yeah, you're fine. We just go off it for 2 days. You can start it back right after the procedure.
Thank you, sir.
Yeah, no problem at all.
And doctor, are you the one who performs the procedures, or do you have others in your office that do that?
No, I am the only one until my son is in his middle of his residency and fellowship right now, and he will be joining me in about 2 years. So, but right now I'm the only one with the staff. I've got 3 nurses, x-ray techs, and front office, but who assist me. There's usually 3 of us in the room at the same time.
Okay, thank you.
Sure.
I have a question.
Mm-hmm.
Does this work for erosive osteoarthritis also?
Absolutely, yes.
Okay, so if I have severe erosive osteoarthritis and you can't even see the joint in the X-ray,
It all depends. Yes, and so you see no joint. What joint is it, first of all?
it's finger joints, and it's 12 of my finger joints are severe
on your
severe erosive osteoarthritis.
So what I do with those, and is it like which joints, do you know the names of which joints, or basically would it be out towards your fingernails or closer to your hand, or?
Both.
Both, okay. So what I do,
I think they call them dips and pips.
Yep, DIPs and PIPs. What I'll do for those, I don't do stem cells for those. It's too small of a joint, and you can't get anything in there without damaging the stem cells. But I will do PRP. So I typically kind of try to get PRP in those joints, or at least surround the joint with platelets. And oftentimes we'll see. The problem is you're kind of between a rock and a hard place. You don't have many options for that. So yeah, no, we do that quite a bit, and we have fairly good success. I'm going to say it's not 100%, but it's pretty much the only thing to do for them. And there's no sense to spend the money to do stem cells. It's much better to just do the platelets.
So most of the joints are frozen?
So they don't move at all?
No.
And but they're painful?
Oh yeah.
Yeah. So basically, and I just did one yesterday, actually, we basically just kind of surround the entire joint with the platelets. And I would say, pick a couple that are the worst and try those. And then if you're like, you know what, this made a difference, then we can always, I wouldn't want to do 12 at once, but we could do, limited amount at one time and another time if you got results from it.
Okay, and does insurance cover that?
No, unfortunately. Insurance, it's a lot of politics involved as to why stem cells are not covered by insurance. And the reason being, I was at UW for many, many years, and you do a total knee replacement at UW, the hospital is going to net somewhere around $110,000. They don't want to see that go away. And the hospitals in general, with the exception of places like Fred Hutch, where they're doing their cancer hospitals, are run by the orthopedics departments because they bring in the money. And so the ambulatory surgery centers, the hospitals, the surgeons who are doing total joints, and the prosthetics companies make a lot of money from doing total joints. But if you look at places like the largest orthopedic centers in the country, Mayo Clinic, Cleveland Clinic, Johns Hopkins, Harvard, Stanford, Kerlan Jobe, Stedman, they're all doing stem cells. So, because they work. But yeah, insurance is still kind of behind the 8 ball on that.
Okay, so platelets is considered stem cells still.
Well, it's considered regenerative medicine, and typically insurance companies don't cover that.
Oh, okay, regenerative medicine. Okay, thank you very much.
Sure.
Question?
Yep.
I have AFib and take Aliquis for that, and have had a heart valve replacement. Does that still enable me to consider this or not?
What joints are we talking about?
Knee, right knee. Bone on bone and the x-rays.
We can leave you on the Eliquis for knee. I mean, it's not an issue. You wouldn't need to go off of it.
Okay.
Have you gone off of it for procedures in the past?
Yes, I have.
Oh, and your cardiologist didn't have problems with that?
For 3 days, yes.
I'd maybe have you go off it for a day. That would be all I would do.
Okay.
The other thing is, I'll tell you, I'd say 95% of the time that patients come in and they were told by their surgeon that they were bone on bone, they're not. The reason being, I found this out just a couple weeks ago. I ski with these guys who are on the board of Primera Blue Cross, and in order to get insurance to pay for a total knee replacement, the term bone on bone has to be in the dictation.
Oh, of course, yes.
So, because I'd say there's so many times people bring their films and they say, oh yeah, I don't think I'm a candidate because I'm bone on bone. I said, well, let's look at the films. I said, well, look right here. You got this much joint space. You're not anywhere near bone on bone. And unfortunately, that happens a lot.
Okay, thank you. One other quick question.
Sure.
Could you address the pain issue as regards the injections into the hip? That kind of scares me.
Oh, you mean the bone marrow aspiration?
Yes.
Okay, so I've done like 25,000 of them. It takes me less than a minute to do a bone marrow aspiration.
Oh.
Half the patients are, you kidding? You're done already? And half of them are like, holy shit, that really hurts. It feels like a deep ache or like a vacuum type sensation, or some people describe it as sciatic nerve pain going down their leg. We give everybody pain meds. If it's painful, it's going to be about 30 seconds.
Okay.
Yeah. And then the pain, as soon as that needle is out, the pain is gone.
Okay.
Dr. Wagner?
Yeah.
I've heard that cartilage cannot be regrown. Is that?
No, that's wrong.
true?
Cartilage, all these studies that we went over earlier show that cartilage definitely can be regrown
So why are professionals saying otherwise?
because they want to do total
They're
joint
MDs,
replacement.
yeah. They're not PAs or anything. They're people in sports medicine at the clinics, in different areas. But I asked
Yeah.
the question, and they said, no, you cannot regrow cartilage. It's like,
Well,
are they just how could they be
I think,
uninformed?
and some of it may be, they're in orthopedic offices. And that's the reason I left University of Washington, because they just weren't willing to do stem cells. And it's all purely a financial thing. But, we end up doing, anecdotally, we'll have somebody come in 5 years after a stem cell procedure with another injury to the same joint. and we'll get an X-ray, we'll get an MRI, and I'll say, well, look at this. I mean, you had a meniscus tear 5 years ago, and now we don't see any evidence of it on the MRI. Or you had this osteochondral defect. There's nothing there now, or you had a partial rotator cuff tear, which looks fine now. So we see it all the time. Plus, all these studies that those 10 studies that we read off earlier in the lecture, all document that you can definitely regrow articular native cartilage.
So, and that's what's in osteoarthritis.
Yes.
Okay. Thank you.
Sure.
Doctor, quick question. Is this effective for frozen shoulders?
Frozen shoulders, there's usually a problem going on as to why you have the frozen shoulder. But yes, I treat a bunch of frozen shoulders with it.
Okay, thank you.
I have a question.
Mm-hmm.
I was told I have arthritis and a meniscus tear in my left knee, and I am scheduled to go get a PRP injection next week. But after listening to you, is that how I should go, or should I go more towards the stem cell treatment?
So they told you you had osteoarthritis. Did they say, was it like mild or moderate or severe or what?
Just mild, just the start of it.
Okay. And a tear in the meniscus.
That's right.
The medial on the inside?
Yes.
Okay. So PRP, it's probably going to feel better after the PRP, but it may only be a few months. So PRP by itself decreases inflammation. It is not going to heal the meniscus tear, nor is it going to do anything for the osteoarthritis, but it does decrease the inflammation. So yeah, long run.
It's a temporary fix.
Oh, I'm sorry. How old are you?
I'm 50.
Okay, so you're young. I mean, you probably want to fix that tear, then what you do is you do PRP with the stem cells. Because there's a very good chance that if you just do PRP, you're going to be back in again in 6 months doing another PRP, and then maybe every 6 months to a year afterwards.
Okay, I had assumed they were the same thing until my injection's going to be $650, and then you said stem cell treatment was between $7,000.
Yeah, no, it sounds like you're just getting platelets.
Okay. Thank you.
Sure.
Dr. Wagner, how many other doctors around Seattle area do what you do with stem cell treatments?
So there was a guy by the name of David Brown who has done it for, maybe he did it a little longer than me, 11 or 12 years. Unfortunately, he passed away about 2 years ago. I would say there's maybe another 3 or 4 who are doing it in this area. There are a lot of people in California doing it, Texas, Florida, Colorado. So I mean, there are people all over the country who do it, and it's being done at a lot of major, research centers and clinics around the country as well. I think based on the people who supply all our surgical supplies, we've done more than anybody in the Western United States. We take care of a lot of professional athletes too, so we kind of have a lot of high profile patients who are sending people our way. We see a lot of international patients. We take care of a lot of the professional teams. So, but there's 1 or 2 guys I think on the east side. I don't know, like as far as chiropractors who are doing it. I know there's a lot, but you got to be really careful with that.
Do you know if stem cell treatment works for foot neuropathy?
So here's the thing with neuropathy. There's a treatment, and it's called MVASC. And it's micronized vasculature. And I want to do it, but Medicare is throwing a huge monkey wrench into being able to do it up here in Washington State. It's not covered by insurance, but we just can't even get a code number from Medicare because I have a bunch of patients who want to do it. And it worked. It was developed by a guy out of Harvard and a guy out of Stanford who were molecular biologists. And I've seen the data on it. But we haven't been able to use it up here. We just can't, even though, like I said, patients always go, well, I'm going to pay cash for it. Well, doesn't matter because Medicare has their hands in everything, and we can get in big trouble if we do things. But yeah, for peripheral neuropathy, I send people down to a guy in Vegas who's doing it, Baumgartel. For some reason down there, you can do it. So it's MVASC, MVASC.
Thank you. That's very helpful. And you feel confident with this doctor down in Vegas? I mean, you would give him good recommendations?
Oh yeah, yeah. No, he's good. And what I would do is you can always call my office and they can get you his contact information. And he'll do like video, like a Zoom consult and such.
Great. Thank you.
Sure. Any other questions?
Doctor, you had mentioned for the frozen shoulder, there should be a reason for that. How do we identify what exactly caused it?
Oh, have you had an MRI on that shoulder?
No, not yet.
Okay, so that's what I would do. And we can do it here, or your provider who you're seeing hopefully can get one ordered for you. But it's important that you do an MRI it has to be done a certain way. It's with contrast. And then typically there's something else going on in the shoulder joint that has caused the problem with the frozen shoulder.
Okay, and will the insurance cover that MRI? Because I heard like we need to go to the surgery stage to get it approved by the
No,
insurance.
it shouldn't be. What's your insurance?
8 now?
Yeah, it shouldn't be. I mean, the nice thing is we have a really good relationship with all the MRI facilities. We use Reyes, and we get them all covered. So it's just a matter of sometimes jumping through a few hoops, but shouldn't be an issue.
Okay, cool. Thank you, Doctor.
Yeah.
How many MFCs do you get in a knee injection?
How tall are you?
6'2".
How old are you?
I'm 72. I had it several years ago and it worked really good, but my left knee is starting to hurt again. It's been about 5 years.
Yeah. We're going to get somewhere around 2.5 billion.
2.5 billion.
Yep.
Okay.
We'll let you count them so we can see how close we are.
Well, I will be there. I will count every one of them.
They do have a machine in Florida, in Lakeland, Florida, at the M site, which they do count the stem cells. So that's kind of how we know ballpark, by age and size, how many stem cells we're going to get.
All right. Well, that's good information.
Sure.
Yeah. So I'll probably be getting in touch with you in the next month or so about my issues. My knee thing, it's not, the pain I have there is different now than I had before. So it might be something different. All right.
Oh, okay. Well, yeah, we'll take a look and see.
All right. Sounds good. Thank you.
All right.
Dr. Wagner, if you have multiple joints done at the same time, this sounds like that's going to make physical therapy rather complex.
Not really, because you're still doing, this is not like, it's not like a total joint or a big surgery. You're walking, you're doing activities of daily living, you're using your arms, your shoulders, your wrists, your hands, and it's just you're not going to be using I don't want you to, go out and pick up basketball or put an addition onto your house. But, typically, what joints are you talking about?
Shoulder, hip, possibly Achilles.
Yeah. I mean, it shouldn't be an issue. And where do you live?
Lake Stevens.
Lake Stevens. So we would just refer you to, we have physical therapists everywhere who we know well, who treat a lot of our patients. So if you don't have somebody, we usually kind of give you some good referrals to some people to see.
Okay, great. Thanks.
Yeah.
I had one more question, doctor, if I could. I have access to several databases, including UpToDate. And I was wondering if we could have the research journal articles that you cited so that we can read those, like from the
Sure.
Journal of Bone and Joint Surgery. I think they'd be very, very interesting.
Yeah, basically, so this presentation, the PowerPoint, and Jensen, are you still on?
Yeah, I'm here.
Okay, they can get the presentation right on YouTube or get an email or somehow get the presentation so she can get those slides.
Yes.
Okay, so yeah, it'll be available. You'll also get something from our office. And yes, we can definitely get those for you so you can kind of research them on up to date.
Okay, and thank you so much for your time. It's been a very, very interesting session.
Oh, good, good. I'm glad you enjoyed it.
Hey,
I
Dr.
have
Wagner?
I have one more question.
Sure.
My name is Margie. I actually saw you years and years and years ago. So hello again.
Okay, hi.
I had a pretty bad rotator cuff tear where the supraspinatus was sort of reattached. This was probably 7 years ago. And since then, I've had issues where I had an MRI, but without contrast. And the question is, years and years ago, I was told from a urology study that I did not to use the dye that was involved with the kind of radiology or the type of filming they were doing with the contrast dye. Do you know if things have changed where it's actually safe to do the contrast dyes in terms of like past experience with like an allergic reaction?
So there are different dyes that if you had a reaction to the dye, I mean, the radiology facilities are well aware of that, and they'll use a different type of dye. But sometimes you don't need, what did your MRI show?
It showed that there had been an increase of there's now osteoarthritis. I've had a lot of physical therapy. I was told that if I wanted to, I could come back for a cortisone shot. But also there might be some bone spurs, or I think you're calling it maybe chondromalacia. I don't know, but there's been some changes because of just ongoing wear and tear.
But definitely they saw osteoarthritis.
Yeah, definitely.
So you don't need an MRI arthrogram. You don't need the dye because that's enough reason right there. Plus, given the fact that you had this rotator cuff surgery in the past, to do biologics. If we did it with the dye and we saw a partial tear, of the rotator cuff or the labrum, it wouldn't change our decision process.
That's interesting because I actually was having it done to ask them if I did have another tear, and from what they could see, they said no.
Okay.
But you would still want to see those films, I imagine.
Yeah, I'd like to see them. Do you have full range of motion and good strength?
Interesting question. I still do things, but it's painful now. Like for swimming, I'm having a lot of trouble, and I do have I really did have a fairly good recovery in terms of range of motion.
Okay.
But swimming is a problem, and I've worked a lot with physical therapists to try and figure out if my stroke is really working the way it should. And it just seems like it's cantankerous.
Yeah.
That's the best way I can describe it. And it can really bother me in terms of sleeping.
Oh, okay. So yeah, that's the osteoarthritis. And even if there's a partial cuff tear, wouldn't change our decision. We would say do the stem cells. Even if it was a labrum tear, a rotator cuff, and osteoarthritis, though all three of those respond very well to biologics.
Awesome. I was afraid that needing the contrast in the MRI was going to put the kibosh.
No, if it showed the arthritis, we don't need to redo it with contrast.
Okay.
Yeah.
Thank you.
Sure.
Hi, I have two questions.
Okay.
How much is PRP?
PRP is typically somewhere right around 1,100.
And if one is doing both knees, how much would it be?
Then it's about 1,800.
1,800. And I have had ACL surgery on one of my knees, which I really wish I hadn't. And I had that done about 10 years ago. Would I be a good candidate and I have osteoarthritis currently.
You do?
Would I be a good candidate? And I'm not bone to bone yet. I
Yeah,
still
so
have
the
some.
earlier the better. The earlier you do the procedure, if you catch it early on, patients do better than if we wait too long because it's a weight-bearing joint. It's just going to get worse with time.
Okay. And would you recommend PRP and stem cell therapy both
If you
together
have,
at the same time?
yeah, if you have osteoarthritis in the joint, you want to do stem cells and PRP.
Okay. And I know my doctor was Dr. Hudson, and he recommended PRP, and he does not do a stem cell. So you think to do both of them
Yeah,
at
you
the
know, if
same
you have
time?
osteoarthritis and anything else going on, I mean, the PRP, once again, it's temporary. It might give you a little bit of relief, but in the long run, it's not gonna heal anything for you.
So why would I do both of them at the same time?
Because
That's
so when you do PRP in combination with stem cells, it's basically fertilizer for stem cells. So you
oh,
want to do it with the stem cells.
okay. And so how much would it be if I just do one knee and
So a
do
knee
stem cell
is 7,700
for both of them?
for one knee for PRP and stem cells. Yeah.
Okay, got it. Okay. All right.
Okay.
Is this also, can this be preventive, like to do it on the other knee that is still a good knee?
Well, it all depends. If there's some minor changes in that knee, yes. But if it's like if that knee is 100% and you don't have any issues there at all, I don't see a reason to do it.
Okay. All right. Great. Thank you
Okay.
so much. Very informative. I appreciate you.
Oh, thank you.
I have a question.
Uh-huh.
I have a pacemaker. And you've been talking a lot about MRIs, which is not recommended for someone with a pacemaker. Are there other options for getting what you need to see?
What's the joint that's involved?
Hip
Hip?
and mostly hip, knees a little bit, but mostly
Okay.
hip.
And have you had any x-rays?
I haven't had a recent X-ray. I had my right hip replaced, and I still have a lot of muscle pain in my right leg. And now my left leg, it's hurting to put weight on my hip.
It might be that all we need to do is a recent x-ray to be able to see. Because if we see changes on the x-ray, we don't need to do the MRI.
Okay.
Yeah.
Okay.
And we
Thank
do
you.
x-rays here in the office.